Good morning, everyone. I'm joining you today from Ottawa, Ontario. I would like to start by acknowledging that the land on which I sit and welcome you from is the traditional territory of the Algonquin people. Welcome to the Canadian Society of Addiction Medicine Fundamentals course on behalf of myself, Dr. Melanie. This morning, I would like to tell you a little bit more about CSAM and encourage you to become a member. CSAM is a national society of medical professionals and scientists committed to helping Canadians understand and recover with dignity from substance use disorders. Our strategic directions include educating health professionals, promoting and disseminating best practices, convening tables for dialogue and consensus building, and advocating for meaningful change. I have been a member of CSAM since 2005. I am the current past president of CSAM and have been on a board member since 2012. I can speak to the amazing national networking opportunities that being a member of CSAM provides. In addition, becoming a member will give you discounted access to our annual meetings, conferences, and webinars, and comes with a subscription to the Canadian Journal of Addiction Medicine. The Canadian Journal of Addiction. You'll have exclusive access to our member directory, addiction job postings, and referral resources. Plus, you'll be eligible to participate in our governing committees. If you are currently a student member, membership is free. Please consider joining. All of you are welcome. I will now turn it over to my colleague, Dr. Ron Fraser, to provide an overview of the day.
Thank you very much, Dr. Willows. My name is Ron Fraser, and welcome to all of you. I don't know where each of you are and what the weather is like there, but here in Nova Scotia, it's a spectacular day, the perfect sort of day to be in your basement home office online. So we really appreciate you joining all of us and taking the time out of your very busy schedules and out of your weekend to learn more about something that we're all very passionate about, which is addiction medicine. The day is broken up into 3 blocks. The first block will be this morning. I'll be speaking about biopsychosocial model of addiction. Dr. Martell will be talking about assessment and diagnosis. After lunch, beginning at 12:30, we'll have Dr. Willows talking about alcohol. I will again be back to speak about sedative hypnotics. Dr. Etches will speak on cannabis use disorder. And then there'll be a 30-minute block where there'll be a specific question and answer period. You'll be able to put your questions all along in the chat, and then they'll be addressed at the Q&A portion of the day. We'll then have a break for 15 minutes before having our final block, block 3, which will be Dr. John Fraser, no relation, speaking on opioid use disorder, Dr. Crockford from Alberta speaking on stimulant use disorder, and then the current president of CSAM, Dr. Brash, will speak to us about concurrent disorders, after which there'll be, again, a 30-minute question and answer with the block 3 speakers. So I'm going to just introduce myself because I'm moderating. My name is Ron Fraser, as I mentioned earlier, and I'm an addiction psychiatrist that works at the McGill University Health Center at the addiction unit there, where I'm head of the inpatient services. And in addition to that, I also run a treatment program for severe and persistent borderline personality disorder. So today, we're going to start by looking at an overview of the biopsychosocial model of addiction. And I think I have control, except let's see. Oh yeah, I forgot that part. Click the presentation twice. There we go. Thank you so much, Rob. So I have no conflicts of interest or commercial support to disclose. This is my contact information. Feel free to email me with questions or comments or concerns. If you're looking for resources, things like that. Usually I get a handful of emails each year, and that's perfectly fine, and I'm happy to receive those. So this is the objectives for this morning's talk. We're going to define addiction using the American Society of Addiction Medicine criteria. We're going to examine the contributions of agent, host, and environment in the development and mitigation of addictive disorders. And then we're going to talk a little bit about the neurobiology of addiction as well. So if you're at this day, you're probably well aware of the psychosocial costs of addictions globally. This is a major issue in all aspects of human society, with 31 million people worldwide with a substance use disorder. There are tremendous consequences to addictive disorders. You know, I think all of us are aware of the opioid epidemic and all of the mortality and fatalities that have subsequently come from that. We may be less aware of the fact that, you know, we have other addictions that have equally high mortality rates, although albeit not at such a young age necessarily. So in Quebec, where I work, one person dies every hour from tobacco-related causes. There are tremendous medical consequences as a result of our relationship in misusing substances, both medically and psychiatrically. Crime and incarceration, it's really significant in terms of the role that this plays. I remember being at CSAM conference in Vancouver, and there was a Crown prosecutor who was Indigenous in the Northern community, and he talked about the fact that he had never prosecuted a case of homicide or domestic violence that did not involve alcohol. And really that was a very powerful message. Sex works and sexual violence, certainly the cost of in youth protection and within families, loss of employment and productivity. And then societal. We're sort of seeing this more and more. Many of us are shocked when we see what's going on in our communities because we've been very sheltered growing up. We've had the good fortune to grow up in privilege and not be exposed to the psychosocial costs of vulnerability and being disenfranchised, and all of the costs that are associated with that. And certainly substance use disorders is a major contributing factor to all of these sorts of things. In Canada, the direct and indirect costs of addictive disorders is $40 billion a year, which is a mind-boggling number. So how did we get here? Well, it really stems from biochemical false promises. We have this belief that we can use mind-altering substances in a way that will enhance our lives. And of course, that is possible if you have a healthy relationship with substances. It's not possible when you have an unhealthy relationship with substances. So in 3300 BC, we're not going to walk forward. We're just going to stick there so you don't have to panic. In 3300 BC, the ancient Sumerians were the first people to develop writing, so we know what they were doing. And they were the first agrarian society that settled. Prior to that had been nomadic lifestyles for everyone. And what they would do is they would trade with the nomadic tribes And they had three principal crops. Number one was wheat for bread. Number two was hops for alcohol. And number three was something that the Sumerians called the plant of joy. And this is what we would call the poppy. And they would use that for opium. So historically, human beings, their history has been intertwined with our relationship with different substances and the effect that they have on us. These can be healthy relationships, they can be unhealthy relationships, they can be sort of in between. It can be part of our cultural practices. And then, of course, what we often see is we take things that are, healthy within one culture, and we blocking on the word, take it to our own culture and don't necessarily use it in the same context, and it becomes problematic. So the historical models of addiction in the West certainly are most shaped by Judeo-Christian tradition. And this is really what's influenced us the most, in that it's, still to this day, largely looked at from a moral perspective, a moral failing, a lack of fortitude, being sinful, being bad. And then even when we started to look at it from a medical or psychiatric perspective, it still was, looked at through that lens in part in terms of physiological failings as a result of weakness. Even in DSM-2, things like heroin were not viewed as addictive. And addictive disorders were conceptualized initially as personality disorders, and it wasn't until later that they began viewed as something other than a characterological failing. Other cultures have different perspectives on this. I'm certainly in no way an expert on indigenous perspectives, but the idea of scarcity of mind is quite fascinating to me, and because of it's the idea that people chase what they feel that they're missing, and certainly that seems to be applicable to this population. Within ASAM, their definition of addiction talks about addiction being a primary chronic disease of brain, reward, motivation, memory, and related circuitry. The dysfunction of these circuits leads to characterological, biological, psychological, social, and spiritual manifestations. And so what we always try to argue, and I think there's a lot of evidence for this, is that addiction really is the ultimate biopsychosocial spiritual disease. And all four of those components are essential to be looked at in terms of the development of the addiction disorder, but also the looking at effective treatments and interventions. You have to look at all four domains, not necessarily all equally, but you have to regard all of them in order to have the most effective treatment outcomes. And this is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. And we're going to talk about that a little more in depth further on. So at its core, addiction really is about a loss of control. We get to the state where our relationship with the substance is now controlling us. We're unable to control it. And as a result, we go from using impulsively to using compulsively. And then, like other chronic diseases, it has periods of relapse, periods of remission. And, I was a psychiatrist, people don't get, enraged when their patient with bipolar disorder or their patient with schizophrenia suffers a relapse. But oftentimes people become very angry, very frustrated, react very strongly when their patient with a substance use disorder suffers a relapse, even though it's part and parcel of the chronic disease model. And then finally, without treatment or engagement in recovery activities, addiction is oftentimes progressive and can result in tremendous disability and premature death. And as with many diseases, it doesn't just impact on the individual, but impacts on their entire social network, impacts on their families, their children, their loved ones, and the society around them. So when we look at risk factors for addictions, George Valiant described this very well, talking about 3 components. First of all, there's the agent, and we're looking at the drug. People talk about drugs and alcohol, but that's a bit of a misnomer because alcohol is a drug. It's a little bit like talking about carrots and vegetables. Carrots are vegetables. So the agent, the availability, the cost, the rapidity to reach the brain, efficacy as a tranquilizer to relieve withdrawal, and a real illustrative example of this is society's relationship with tobacco and the interventions that we've made in terms of reducing the public health costs by taxing the bejesus out of it so that the cost becomes prohibitive, taking all sorts of measures to reduce availability, particularly to young people. But at the same time, cigarette companies have designed cigarettes so that they're optimally addictive in terms of the delivery of the nicotine system. We see this now with vaping as well, where they've tried to move from one thing to something that's more socially acceptable and increase uptake. And of course, nicotine cigarettes is a very effective way, in fact, the most effective way of treating nicotine withdrawal. Then there's the host or the individual. There's certainly genetic predisposition, the multi-problem families, comorbid psychiatric disorders. There is no psychiatric condition that reduces your susceptibility to developing an addictive disorders. They all increase your risk, but not all to the same degree. Different disorders have a different increase in risk. And then your age, gender, perception of risk, all of those things factor into development or protection of developing addictive disorders. And then environment is particularly important. Where we grow up makes a difference. Our culture, our societal network, our peer group, all of those things are the people around us, their relationship, and how we look at our relationships with particular substances. So for example, the typical Canadian has a very different perspective on the use of alcohol versus the use of intravenous drugs. And all of those things have an impact. So when we look at genetic risk, biological sons of fathers, and it also appears to be biological daughters of mothers with alcohol use disorder have an increased risk of themselves developing alcohol use disorder, even if they're not raised with that biological father. Certainly there's a wide variety of genetic differences in terms of how we metabolize different substances. So if we're a fast metabolizer of alcohol, that actually increases our risk as young people, because if I'm a very fast metabolizer, I have to have 6 or 7 beers to have the same effect as my peer that they get after 2 beer. So right from the very beginning, I'm learning a dysfunctional way of drinking. 25% of the Asian population lack the enzyme acetaldehyde dehydrogenase. They're not able to metabolize alcohol. They have an aversive reaction, and none of those individuals is going to develop alcohol use disorder. that, of course, does not protect them from any other addictive disorders. People may have differences in terms of their dopamine receptors and how that affects their reward pathways. And then, risk-taking behaviors, impulsivity, propensity for novelty seeking versus propensity for harm avoidance. All of these things are partially genetically determined and can influence our development of alcohol use disorder. Socially, certainly role modeling is very important. And our main role models in life are our parents, obviously. Family disruption, chaotic environments. We know that like simple things are protective, things like having family dinners together each night, going on family vacations. We know that these are protective. What they're probably representative of is a cohesive family, more so than the particular importance of family dinners. Using substances as a coping strategy, and it's spectacularly effective coping strategy. Short term, it works, right? That's why people do it. The problem is it's a spectacularly poor coping strategy long term. Certainly the economic of addictions is important. And it's not just the tobacco industries and the drug cartels that drive the market, although that is true. But the reality is that governments are addicted to addiction. If we took away all of the revenue from tobacco and gambling and now cannabis, we'd have an economic collapse. Gambling and alcohol alone generates $2 billion a year in revenue for Quebec. They can't afford to give that up. So they're at a conflict of interest in terms of, on one hand, needing to generate tax revenue for societal programs, and on the other hand, having to protect the health and wellness of their population. So psychiatric disorders, we touched on this earlier, increased lifetime prevalence of psychiatric disorders in those that abuse substances, and the reverse is true as well. Certainly, many substances are associated with substance-induced mood disorders, substance-induced psychotic disorders, substance-induced anxiety disorders. Alcohol being the one we see the most, because alcohol is by far the most prevalent substance used in Canadian society. Stimulant use disorders and mania or psychosis. Many of you are probably aware that we have many young people using unprescribed stimulants as study aids or athletic aids, and these are not benign medications, and sometimes vulnerable populations, it precipitates a psychiatric disorder. We've known for a long time the relationship between THC, cannabis, and the development of schizophrenia, which is ironic because now, if you go online, cannabis is trumpeted as a treatment for schizophrenia. Now, it may be that there may be some role for CBD, but there clearly is no role for THC, despite what you read online. And then certain personality disorders tremendously increase your risk of having a dysfunctional relationship with substances, particularly antisocial males. So if consistently, we know in methadone maintenance programs, 25% of the population there have antisocial personality disorder. So it's wildly disproportionate. Dr. Brash is going to talk more about adverse childhood experiences, which is tremendously important for a wide variety of things, but in particular, tremendously increase the risk of developing a substance use disorder. And unfortunately, if you work with this population, you hear some really heartbreaking stories. But you also see some tremendously resilient human beings that have managed to survive things that I'm fairly convinced that I would not have survived. This is the psychological cycle of addiction. And this is what I was talking about the fact that it actually does work. I mean, human beings are not stupid. They do things because they work, but they work in the moment. Human beings aren't so good at looking at what works in the long term. They're much more geared towards immediate gratification. So something hurtful happens to me. I'm emotionally upset by this, distraught. Perhaps I have a fight with my partner. And I do not like feeling like this. I do not like feeling negative emotional states. I don't know anyone who does like feeling negative emotional states. And I want to stop feeling like this. I want this pain to go away. And I know from past experience that if I take a couple of Ativan or a couple of rather lorazepam or a couple of hydromorphone, that this will take away that emotional pain and I'll be distracted from it. And so I start thinking about this, I start craving this, and then eventually I use my lorazepam or I use my hydromorphone, and it works. But the problem is that this effective short-term strategy is spectacularly poor long-term strategy, and it creates subsequent negative consequences. So now my partner is upset. You said you wouldn't do that again. You're high. This is the last straw. Depression, guilt, shame, and around we go. I think I'm actually, because of time, going to move beyond this actually and move on to dopamine. So just as a caveat, everyone has copies of all the slides from today's presentations. So you'll have those long term. So dopamine is a major neurotransmitter. It's involved in a wide variety of things. You certainly would not want to go through life with no dopamine. Important for release of many different activities, but it also has an important role in addiction. So the reward pathway really was something that developed in our primitive brains, and it's really necessary for survival for the individual and survival for the species. And we're hardwired to seek pleasure of activities that will keep us alive, both as an individual and perpetuate our species. This pleasure pathway drives us to eat and drives us to want to reproduce. And it's not just that we're driven to do those things, we're also driven to take risks to do those things. So, we'll go up against the mastodon with our puny little flint spears, and we'll race alongside bison trying to drive them off a cliff. We'll do all sorts of things that we need to do in order to be able to eat, but that are not necessarily safe. If we wanted to be super safe, we just never would emerge from our caves, but then we'd starve to death. And so this all developed in our reptilian brain when we came out of the primordial ooze. We emerged, and one of the first things we did when we emerged from the primordial ooze is that we ate. Probably not hamburgers, Pepsi, but probably frogs, fish, whatever was available. And our reward center, fire. And I mean, it's not what we're literally thinking because we're crocodiles, and crocodiles aren't really members of Mensa, but it's telling our brain that was pleasurable. I have to do that again sometime. And then after my meal of fish and frogs, I see a lady alligator and I go courting. I don't know how many of you have ever Googled crocodile sex, but this is the most appropriate picture I could use. Bit of a traumatizing experience. And this is important because it ensures the survival of the species. And so what happens with addiction is that these pathways and this reward center gets hijacked. And we're of the opinion that gambling, alcohol, cocaine, whatever, our primitive brain mistakenly believes that this is necessary for survival. And that's why we're so driven to do it. And that's why it looks so irrational to outsiders. You know, family members, I just don't understand why they keep doing this. It makes no sense. Well, yes, because it's your irrational brain that's driving the behavior. It's not your frontal lobe that's driving it. In fact, your frontal lobe's impaired and it can't put the brakes on like it normally would. So when we look at dopamine levels of food and sex, you see that it's in the domain of 150 to 200. All the specifics isn't so important. It's just the relative aspects of it. And then we compare that to drugs of abuse like amphetamines. And there's a reason why people who are deep in the throes of addiction are no longer interested in food, no longer interested in sex. All they're interested in is their substance of choice. And they're being driven by their primitive brain because it's convinced that it needs this in order to survive. This is looking at brain dopamine transporters. This is looking at the normal control. This is Dr. Martell's brain here. And then looking at someone 1 month in recovery, and you see, you know, why are they at high risk of relapsing? Well, their brain is still profoundly impaired, right? And after 24 months of abstinence, you can see how now it's really resembling back to normal. That's a long time for the brain to recover. And in theory, this is one of the arguments for some individuals requiring long-term residential treatment because they need to be in a safe, secure environment where their brain can be allowed to heal. Oops, I need to go back one. Right. So other neurotransmitters certainly are a big part of the picture as well. Nothing in the brain really works in isolation. And memory in particular is important because you have to actually remember the experience. So that's what you're chasing. You're chasing that experience. And how long does the brain remember? Well, it remembers for quite some time. So you remember those Hinterland Who's Who videos? You're watching the video of the Canadian loon or the beaver, and nothing happens, right? Your brain doesn't light up. But then you show the brain, and this is in patients that have been abstinent for a year. You show a video of someone using cocaine, and it lights up. It's like, I remember that, which is why for many people, they remain at risk quite long term because the brain does not forget. So this is a conceptual framework of the neurobiological basis of the transition to excessive drinking. And it's a good model. It's a complex model, yet it's also a simple model looking at all of the things that transpire, that develop as we go from having a healthy relationship with alcohol to an impulsive drinking pattern to a compulsive drinking pattern, and then we have an alcohol use disorder. And it's all about the changes that come about in the brain. So chronic alcohol or drug use ultimately results in brain changes, fundamental changes in your neurobiology, a susceptibility that did not exist prior to your developing this relationship with substances. And this is important to conceptualize and recognize that people need an opportunity for those changes to be reversed, which they can be with time, and to recognize that there's going to be a period of vulnerability. AA understood this very early on, long before we had PET scans. They had this idea that there seemed to be this 3-month period where people were at most at risk of relapse. And so they had this whole idea about, well, let's do 90 meetings in 90 days, right? And lo and behold, once we had PET scans, we realized how much change occurred in the first 100 days. And that was a high vulnerability period. Ooh, whoa, 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 whoa. I did something horrible, but I don't know what. Where I left off. Oh, yeah, okay. So obviously, in order to develop any sort of addictive disorder, you actually got to be exposed to the substance. So sometimes you'll see people who are quote unquote completely abstinent of all substances, which is a bit unusual in Canadian society because 80% of Canadians drink. And when you ask them why that is, oftentimes they'll tell you because they grew up in an environment where there was an unhealthy relationship with substances, and they swore to themselves that they would never be that person. So they've never exposed themselves to the substances of risk. Or you may grow up in a society or a culture or a religious group where those things simply are not permitted, and you're not going to be exposed to those risks. Similarly, you may grow up in a society where those things are introduced early, and maybe they're introduced in a healthy manner, and maybe they're introduced in a more dysfunctional, unhealthy manner. Ideally, the later in life you're exposed to something, the better. So there is differences in substances in terms of the risk. There's a lot of different variables that go into this. And so, when people say, well, cannabis is a lot less harmful than alcohol, that's true. That's true on many different levels. But less harmful and harmless are two different things. And I just like this slide because it really gives you a sense of a perspective across the board, looking at what's the risk of dependence, physiological dependence and addiction, and what's the risk of serious harms. One of the things we're not going to have an opportunity to talk about today because of time limitations is behavioral or process addictions, where people are engaged in behaviors rather than substances. So in DSM-5, the only non-substance related addictive disorder is gambling disorder. But I think we've all been exposed to either ourselves or in our families or with our patients, compulsive behaviors that have gone beyond a healthy relationship with whatever it is. Be that shopping, social media, internet pornography, gaming, food, sex addiction. I still have a BlackBerry, believe it or not. I'm one of the few left, but and these are DSM-5 diagnoses, but they're under other specified impulse control disorders. So you can still make a diagnosis, but they're not recognized as addictive disorders as yet. My personal perspective on this has always been, I'm going to treat them as if it's an addictive disorder. And so as far as I'm concerned, to a certain extent, if it looks like a duck and it quacks like a duck and it walks like a duck, it may be a developmentally delayed goose, but it's probably a duck. And so it'll be interesting to see what's added in DSM-6. So what about prevention and treatment? Well, this is obviously super important. It's also somewhat discouraging. So only 1 in 10 people receive addiction treatment, and it's actually even worse than that. So if you look at the CASA study that came out of Colombia, yes, 10% of people with addiction, and that's not counting tobacco, 10% of people with addiction receive treatment, but of those, only 10% receive evidence-based treatment. So the reality is 1% of people with addictive disorder receive scientifically validated, evidence-based treatment. So I argue that addiction is the worst treated disease in North America. That's the end of the sermon, though. So public health and DSM-5, looking at primary prevention, secondary prevention, rehabilitation, disease management. And of course, just like many, many other disorders, there's no one intervention or treatment that's effective for all individuals because it's a continuum. And so treatment needs to be a continuum as well. Your age matters. The younger you are, when you start using substances, the greater the likelihood that you're going to develop problems. All of us, I think, have seen patients that even I'm still shocked at some of the things. When you see an 11-year-old girl who's using, started using IV drugs, like that's shocking. Those individuals really don't have normal psychosocial development because the severity of their substance use at such a young age. The adolescent brain is very vulnerable and susceptible, and the reality is adolescence lasts till about age 25. The longer we can hold off substance use, the better the outcomes. We know this is true. Yet here in Nova Scotia, it's certainly normative for people to introduce their 15 and 14-year-old kids to alcohol and have, supervised drinking parties in the basement with the hockey team or whatever, with the parents upstairs, with the idea that it's better they do that in that setting. Well, in fact, it's better that they not do it, to be honest. But it's such an ingrained part of our culture that it's very difficult to get away from. And then gateway substances, certainly alcohol and nicotine. But it's not just the substance, it's also sort of, if you're a smoker as an adolescent, you're socializing with a different group of people than if you're a non-smoker. And that, in fact, may be the gateway. So prevention, we talked a little bit about this with tobacco, certainly the importance of how cheap is something. So when I was in university, there was like unbelievably cheap drinks. And it was a problem because people would get falling down drunk. There'd be sexual assaults, there'd be STIs, there would be physical assaults, there'd be unwanted pregnancies. There was all these associated costs related to it. And then eventually that became illegal as a public health measure. Availability, how easy or hard is it to get a particular substance? How socially acceptable is it? And how much perceived harm is there? And we know that this is a big thing, particularly amongst adolescents. So as we have a greater perception of harm, use goes down. And as we have a decreased perception of risk, use goes up. And this was one of the concerns in 2016 with the legalization of cannabis, was that there would be a reduction in perceived risk and that subsequently there might be an increased prevalence of use. And so we try to do a lot in terms of public education and messaging around these things, but we're also offset by what's on the internet, which is telling the opposite of what we're telling about how wonderful cannabis is. It treats your cancer, it treats your schizophrenia, how wonderful hallucinogens are, and all of the things that they fix. And often the messaging is well ahead of the science, and sometimes it's just flat out not true. So primary preventions are available. Family First programs have the best evidence. They're not readily available, however, and this is problematic. All of our addiction funding, so when you look at that $40 billion of Canadian cost, almost none of it is in prevention. it's all in the consequences. So it's the social justice system, it's community services, it's the health system. It's the consequences after the fact. Very little is invested in primary prevention, even though as an economic model, that would be tremendously make a lot of sense. So here's some resources that may be useful to you. Not doing too bad in time, actually. So here's some examples of primary prevention, how to make crystal meth. Not entirely accurate, but you get the idea. The idea is to try and increase the sense of potential harm, the perception of risk, and therefore reduce the use in individuals that have not used the substance before. Secondary prevention is about targeting specific populations that may have increased risk, such as methamphetamine use amongst gay men, and these can be very effective as well. In terms of treatments, treatment again has to be biopsychosocial, spiritual. The biological treatments for some substances are limited, and for some substances are robust. So for example, methadone has a number needed to treat of 3. Like, we don't have a lot of interventions in medicine that have a number needed to treat of 3. In psychiatry, we don't have any. It's the best intervention we've got. So agonist therapy, nicotine replacement, methadone, partial agonist, so buprenorphine for opioid use disorder, varenicline for smoking cessation. Varenicline, in fact, has the most evidence for effectiveness in smoking cessation. Antagonist therapy, so naltrexone is an opioid antagonist. It's useful in the treatment of opioid use disorder or alcohol use disorder or gambling disorder, for that matter. Unfortunately, we do not have the long-acting injectable form. Even Russia has that, but we don't, and we're unlikely to ever get it, which would be very helpful because the major issue with naltrexone is non-compliance with medication. Aversive medications like disulfiram, also known as Antabuse for alcohol use disorder. This was developed in the mid-1930s. We were pretty excited because we just cured alcoholism. That was exciting. Just as a caveat, I was not alive in the 1930s, so I'm talking generally, not me specifically. We still use it, so there's still a role for it. We don't use it a ton. One of the big concerns, of course, is some people are so impulsive that they'll drink regardless and inadvertently poison themselves or unintentionally poison themselves. But there are certain individuals that really do well with an external locus of control, and it can be very helpful for them. And then things that provide symptomatic relief, particularly for withdrawal symptoms. So benzodiazepines, barbiturates for alcohol withdrawal, novel anticonvulsants for that as well. Substituting longer-acting benzodiazepines for shorter-acting benzodiazepines, substituting longer-acting opioid for short-acting opioids. And then we have a number of psychosocial interventions. Cognitive behavioral therapy works for pretty much everything. And I'll be talking specifically about a resource set when I talk about sedative hypnotics. Motivational interviewing, robust evidence of effectiveness now was developed originally for addictive disorders. Now it's used for everything from trying to increase people's compliance with their diabetes regime to their taking their antihypertensive medications, et cetera, et cetera, et cetera. Relapse prevention training, very useful. Many times relapses follow a certain pattern, have a certain predictability, so that you can anticipate them potentially. And then you can develop strategies to reduce the likelihood of relapse. Seeking Safety is a tremendous resource originally developed for women with trauma histories and substance use disorders. Now it's expanded to all genders, but very, very useful, very effective, and quite well liked by the patients. Mindfulness is all the rage everywhere and certainly can be very helpful. There isn't a ton of evidence for it as a standalone intervention, but just like things like stress management and anger management, it's an extremely useful tool, particularly as an adjunct. And then peer support. Peer support's all the rage now, and peer support has been around in addictions much longer than anywhere else. So certainly historically there have been 12-step programs, and the advantage of these is that, well, they work. There was very good Cochrane analysis that came out last July, looking at the effectiveness, very impressive. But also, they're free and they're everywhere. So, in Montreal, there's groups in French, in English, Spanish, young people's groups, older adults groups, women's only groups, gay and lesbian groups, groups for blue-eyed people, brown-eyed people, pretty much anything you can think of, you can find a group. And that's much, much, much easier to access than, say, try to get into a CBT program. And then Smart Recovery is also available. There's not many good things that have come out of the pandemic, but one of the things that has come out of the pandemic is that AA was forced to move into the 21st century. So, if I want later tonight, I can attend an AA meeting in Glasgow, Scotland, right? And then tomorrow I can do one in Buenos Aires. Although, admittedly, I don't speak the language, so that's a problem. But Smart Recovery has always, because it was developed in the 90s in San Diego, it's always been a bit more hip. And so it's always had an online presence with chat groups and things like that. So all of these things have moved virtually. That really has increased access if you're from a rural area. I recently had a patient who only spoke Tamil from Sri Lanka. I was really sort of befuddled as to what I was going to do. Then I just connected him with online meetings in Sri Lanka. 18 months ago, that would not have been an option. So there have been some advantages. Referral to treatment services. Addiction treatment can occur in many, many, many different environments. Oftentimes, I will be doing brief interventions in the emergency room with people that I see once and I never see again, but I have a conversation with them about their relationship with substances. There's a wide variety in terms of treatment settings, a wide variety of treatment intensities. And the idea is ideally to try and match people to the appropriate level of treatment that they require at a given time. But sometimes it's really more about connecting them to an appropriate level of treatment that they find acceptable at that particular time. So it may not necessarily be what you feel is needed, but it may be what they're open to at this particular time. And the idea is that treatment of addictions often is a marathon. It's not a sprint. So you have to have the big picture in mind, recognizing that what some people might identify as a failure today may actually be planting a seed that's going to germinate down the road and blossom and may lead to success in 6 weeks' time, 6 months' time, 6 years' time. And you have to have that big picture to recognize that this is not going to have any quick fix solutions. I think this is important to give people perspective, to recognize that substance use disorders have similar relapse preventions as diabetes, hypertension, and asthma. It's no different than any other chronic disease model. I think BC is the only place that actually changed billing so that physicians are compensated by a chronic disease model, just like with other chronic diseases, recognizing that this is important from a long-term public health perspective. All right, so what about recovery from addiction in a social, cultural, spiritual context? I only have a few minutes left, so I'm going to have to go fairly quickly about this. So depending on your perspective, one of the strengths, one of the weaknesses of 12-step movement was that it was, the American Midwest by older white men who were devout Christians. And now it's less about God and more about a higher power. But for some people, that's a real obstacle. But it is about altruism, about stop harming, start doing good works, and to try and transform yourself into a better person. The Buddhist perspective is really about the wellness model. The idea of craving is the root of suffering. As Hollywood Dick Montesante says in the Sopranos sequel, pain comes from wanting things. I don't think he was a Buddhist because he was a mafioso, but he did understand that one aspect. So the idea, you see many aspects of addiction have adopted components of Buddhist philosophy, and it has been very helpful, and it's really resonated with many people in Western society. And so that's been very useful in helping people to develop a different perspective and to step back, take a look at themselves, at the world, their place in the world, and hopefully to develop a different perspective. And then earlier we talked about Cherokee model and the idea of scarcity of mind. This idea is that people are chasing things that they feel that are that they're lacking, that needs that are unmet, and that this tips them out of balance. And the idea is that you have to get realigned with your life purpose in order to get back on track, to be in alignment, not suffering. And this is done through physical and mental purification through traditional practices. And so each of us brings our own experience from our own upbringing, our own society, our own spiritual and cultural practices. And this shapes how we view addiction, just like it shapes how we view all things. In closing, it's important to realize that we have to have a biopsychosocial spiritual approach to treatment, and we have to treat the entire person and all their needs within their particular social context. And I'm going to stop there. And I'm going to introduce our next speaker, Dr. Martell, who I think is in Lunenburg. I'm trying to.
That is not Lunenburg.
Where are you?
I am in Lunenburg.
Oh yeah. Oh, this is not Lunenburg. Yeah. And I don't seem to be able to bring up my bios. So I'm going to do it off by memory, which is worrisome. So Dr. Martell is president-elect of the Canadian Society of Addiction Medicine, and recently was named the medical lead for addiction medicine in Health, Nova Scotia. So God bless him. And he's been a family doctor for many, many years. And after 19 years in practice, transitioned to addiction medicine and really has been widely recognized as a leader within the community. In fact, has been award winning for his efforts in particularly around destigmatization of addictions, increasing access of treatment for addictive disorders in underserviced rural communities. He works in a First Nations community, and really Nova Scotia is tremendously lucky to have him there. And we are equally lucky to have him agree to speak to us for the next 45 minutes on screening, assessment, and diagnosis.
Thanks so much, Ron, for that kind introduction. I have a few things that I want to go over before I dive into the content of what I'm supposed to be doing this morning. The first is that both Ron and I are coming to you from Mi'kma'ki, the traditional lands of the Mi'kmaq people. And our treaty day was just a few days ago. And I'd like to acknowledge that we're all treaty people. I have two other things that may interfere with me delivering this content. One of them is I have an ancient old cat who, whenever he hears me talking, likes to come into the room and start screaming. So if you hear that, it's not any violence taking place. He is quite loud. I'll pick him up and try to calm him down. And I have had allergy attacks all morning. If I start sneezing, I'll try to mute myself before anybody can hear it. The one error that I'd like to pick up on in Ron's slide deck was the one about the manufacture of crystal meth. He showed a slide where a fellow was mixing paint stripper and Drano into what looked like a martini glass with his shirt off. And I'd like to point out that with anybody who's seen Breaking Bad, that the first thing they teach us in that show is that when you manufacture crystal meth, that you need proper ventilation and personal protective equipment. As a first principle, even the Crystal Palace had that. So Ron, you might want to correct that slide. It's very deceiving. I have no disclosures. I have no financial interests. I'm a volunteer board member at CSAM. I've been proud to be part of CSAM since 2015 and would encourage each of you, if you're not already members of CSAM, to look into joining us. And I've had no direct interaction with any pharmaceutical company from the day I entered my residency on. And that's partly to do with one of my mentors, David Gass, who died tragically earlier this year. For those of you who'd like to contact me, I always answer my phone. That's my cell number and my private email address. If you want to jot it down, right on cue, there's Ronnie. So the learning objectives for my session, the first of them is to list and describe, come on, Ronnie. List and describe the basics of screening, brief intervention, and referral to treatment. To be able to conduct and assess a substance use history, an assessment for substance use disorders, and to be able to diagnose using DSM-5 criteria. I was never very good at mnemonics when I went through medical school. I couldn't remember really any of them. They didn't help me at all. I know they were just kind of memorizing shortened forms, but I would screw up the mnemonic and it would lead me astray. So ASPERT stands for screening, brief intervention, and referral to treatment. I think most of you are familiar with it, and Ron touched on some of the elements of it just in the preceding talk. So what do the words mean? Well, it means that we have to screen to find people who we deem to be at risk, trying to maybe intervene with them upstream, have a conversation with them. The brief intervention part is just a way of interacting, and to engage them, to ask them if they want help changing their behavior. That's an important part, determining a person's readiness to change or stage of change, because it can really affect whether or not this person engages meaningfully. And it is the basis of motivational enhancement or motivational interviewing. So in terms of screening, how do we screen? Well, there are many, many validated ways to screen. The Audit C is just a 3-question screener, and you can look it up and get a PDF version of it and kind of keep it beside you at all times when the opportunity arises. I like the types of screening tools that are the most simple. And the one that I chose many years ago was the single question screener. And it is just the 3rd question on this audit tool, which is basically to ask a person, how many times in the past year have you had 6 or more drinks as a man or 5 or more drinks as a woman? And that single question is well validated in the literature. And if you get a yes response to it, of course, you do more history taking and more screening, but it's very, very sensitive and can be reasonably specific at picking up problematic substance use. The key part to the screening, though, is that it involves getting specifics. How often are you using the substance? How much are you using each time? What are the behaviors around it? What are the consequences that have come from it? I also like to include what benefit do you get from this? How does it help you? Ron alluded to talking about how trauma and emotional pain is very effectively treated on the short term by substances. I want to bring that out, acknowledging the fact that substance use is not all completely negative. And there is the single question screener. So what is brief intervention? Well, there's a framework here that I'll flash up on the screen. Ultimately, brief intervention is maybe a guided conversation, a way of talking with the person in front of you about the substance use that you have just uncovered through your screening. You want people to take responsibility for the change, to that locus of control piece. You want to acknowledge that there is an issue, to bring it out in the open. You want to give advice. You want to give a menu of options. It's just a style overall of engagement. So the purpose of doing this type of assessment I mentioned is to find upstream issues, at-risk substance use before it has become a disorder or a disease. This is kind of a secondary prevention type of deal. You also do want to uncover people who haven't been found already to have substance use disorders. Many people will hide their substance use problems, even to the point of having severe addictions from their loved ones and from their caregivers. I've uncovered many instances over the years as a family doctor where I've discovered someone to have a very serious alcohol problem, and I never knew. You also want to identify whether a person has a co-occurring disorder as early as possible in the process. But also, you want to start the process of engaging to come up with a plan. It isn't just finding it. And I talked about enhancing motivation. Motivational interviewing, I think when I first heard about it and thought I might be interested in it, I thought, oh, this is some involved psychotherapy. It's going to take me forever to learn how to do. And it's a special skill set. And you really have to have credentials to do that. It really isn't. It's a very basic way of engaging with people. And the skills that you learn when you learn motivational interviewing are very basic skills. Guiding conversations. They're really not complicated. Most of you have probably already engaged somewhat in a motivational interviewing seminar or webinar. So when we assess addictive disorders, how does that assessment take place? Well, in medical school, we learn to take a history. What is a history? Well, it's two people. It's a provider and a patient and the space they occupy. But in this context, there are some nuances. One of them that I'll point out is the space. Sometimes the space can be a safe space. Sometimes it really isn't. And sometimes it's not designed to be a safe space. You think about a very busy emergency department being the least conducive place to even talking about a substance use problem. that someone is hidden. The disclosure is unlikely to happen. There are nuances related to the patient themselves, their stage of change, whether or not they're withdrawing from their substance in the moment, that can make it such that you can't even sometimes hold a reasonable conversation with them, whether or not they're impaired from the substance as well. That brings up issues of capacity and consent that we often struggle to kind of know how to navigate. And those co-occurring disorders that can involve a lot of underlying emotions and even cognitive problems. I've had patients in my career who, through their substance use, have had traumatic brain injuries. Think about people who've survived overdoses, people with fetal alcohol spectrum disorder. There may be cognitive issues that have never been diagnosed or have never been uncovered, but that very much interfere with that ability for them to engage. And then there are factors on the provider side. And I think the one that we struggle with at times is just stigma, the preconceived notions that we ourselves have about people who use drugs and that our system has about people who use drugs. And it may even be that the provider has never either practiced or learned some of these techniques that are useful in the context of assessing substance use disorders. We talked about motivational interviewing. So I like to use a lot of different phrasing to guide the engagement. And I think this speaks to the interviewing skills. And I took to heart very early in medical school when they taught me to use open-ended questions. And to the degree that I morphed that into even just using silence. Sometimes when I have someone who has what seems to be a complex problem, I'll just sit and I'll say a very brief something. You know, why are we here? To start talking, you know, something to prompt the discussion. But where do we start is a good one, and to follow it with enough silence that a person knows that the space is safe and that you're not rushed. You see the flavor of these is that they are open-ended. You're not going through checklists. It's just talk about this, tell me about that. I think they lead to more meaningful and rich answers than checklist questions. We learn these things very early in medical school. Learn to use silence, and people will appreciate that. Some people take time to process their thoughts, and sometimes we really don't have the time to spare. It struck me as being something that was kind of disturbing when early in medical school I was shown a research study that suggested that the average length of time it took between when a patient started an encounter and when they were interrupted by the provider was 11 seconds. So through my career, I've kind of tried to ground myself at times by starting in an assessment or seeing a patient and then counting just to see, am I doing better than 11 seconds? I thought that was awful. Like interruptions happen 11 seconds later on average. And be open and feel free to share from your own experience. Patients will appreciate it. Some of the struggle I've had has been that I don't have lived experience and I can't really truly empathize with what this person has gone through. But from what experience I have had, I'm very open about my own emotions and my own life. I'm not saying that this is a way to kind of find ways around boundaries, but there are ways that you can engage without going past the established boundaries. And try to keep in your mind that what you're talking about, well, you think it's this awful thing. We're talking about drugs or alcohol and something you have no experience with that's big and scary and awful. And but think about it in the context of a chronic disease. Imagine what you're talking about is any other chronic disease. And I think that normalizes the conversation. This could be diabetes, this could be asthma that we're talking about. Try to ground yourself as well by, imagining that you have a connection to this person, not a direct connection, but would you treat this person the same way if they were a close friend's nephew, somebody that you don't know but who is somehow connected to you? And moral judgments really have no place in the practice of medicine. And I think this speaks to if you find yourself forming an opinion about someone's behavior that is in the category of a moral judgment, check yourself. This really isn't the place for it. Keep in mind as well, there is no profile. We have visions that people who use substances are, homeless, unemployed, and I've treated hospital CEOs and judges and all walks. Everyone can be affected by this. There isn't a specific profile. So when we're trying to gather a substance use history, there are some key points that you want to try to tease out from a person's history. One of them is their first exposure. And Dr. Fraser had talked about it being important in the context of first use in alcohol and your parents sanctioning it in the basement in a controlled environment. You really want to know, when was that very first time? How old were you? What was the context? From that point, when did you become a regular user of this substance? I think you'll see as this progresses that what we're talking about is a progressive loss of control or development of compulsions or consequences, some of the other things that are wrapped up into a substance use disorder. So first use, regular use, and when did you lose control? When do you figure that this was taking over your life? And if you can frame all of your questions around the substance use, substance by substance, using just this framework, you've gathered a lot of valuable information. And oftentimes you'll come to discover that what you thought might have been problematic use really isn't. I use cocaine. I use it 3 or 4 times a year, and it hasn't created consequences. I never used on a regular basis. I never lost control. Then it has some other purpose. It really isn't a substance use disorder. So these 3 questions are good ones to base your history around. And of course, go substance by substance. When I was in medical school, I was taught to take a social history by asking a person, do you smoke, do you drink, do you use drugs? And that was it. That was a social history. And I don't think I ever really got anything from that kind of social history in hospitalized patients or elsewhere. You really have to be specific. Go class by class. Tell me about tobacco use. Let's talk about alcohol use. And one substance after another. So not an exhaustive list. I use categories, try to define the amounts and the frequency and even the mode of use. And when was the last time you used? Trying to determine, could this be a presentation of substance withdrawal that we're encountering here? And the profiles of substance withdrawal are different from one substance to the other. And they have different treatments and different consequences as well. You want to know how people take their substance. Is it inhaled? Is it eaten? Is it swallowed? Is it injected? And again, this is a point where you would ask somebody, well, what is its purpose? Why is it that you use this? And sometimes people haven't had an opportunity to reflect on why it is that they take it. They may not know. You want to know about a person's history, particularly points in their past where they found interventions that really led to meaningful recovery, things that helped them, because you will want to try to engage them to do some of those same things again. The importance of asking about lengths of treatment for different interventions is that we know from the literature that no one intervention is really superior to others over the long term, that what matters is the length of treatment. And I think this speaks to the chronic disease model. So you want to know, if somebody went through a program, well, how long was the program and what led you to not be in it anymore? Did it come to an end? Trying to feed that notion that we should be looking at longer term interventions or engagement. And of course, what was the most meaningful to you? What led to stability? through this process as well, because of how common co-occurring disorders like mental health disorders are, we want to try to tease out if some of them are present. And I don't think this has to involve a bunch of standardized tools. It can be merely asking people about mood, about anxiety, about hallucinations, about impulsiveness, periods of self-harm in the past. Figuring out with a co-occurring disorder, well, is this because of the substance or is this a separate thing from the substance, can be very complicated. And Jen Brash this afternoon will try to give you a primer on how to properly do this, but you can do some of it in the screening. And one of the ways, of course, is to find out about the timing. Were some of these things occurring at a time where you weren't using substances at all for a period of time? And you also want to know the interplay. If there is something like that present, are there worsenings of it? Like talk about an anxiety disorder. Does it worsen when the substance is used? Does it go away when the substance is not used, or vice versa? You want to know about the interplay of the substance with the mental health symptoms. And of course, if you've managed to get somebody who has had a prolonged period of abstinence from substance use, that gives you a clearer picture. The problem with thinking about it that way is that people struggle at times with substance use throughout their life. It is a chronic disease. And kind of telling somebody, come back when you are no longer using substances and we'll deal with your mental health problem is just an unrealistic thing, that in their lifetime they may never get that opportunity to uncover the co-occurring disorder. So it's best to try to address them both at the same time, the substance use problem and the mental health problem. Otherwise, people fall between that very big crack between mental health care and substance use care. You want to know about someone's medical history. Specific to the substance, some substances can be cardiotoxic, hepatotoxic. We know about alcohol's effect on these. With respect to cocaine use, the same sort of thing. Arrhythmias, myocardial infarction, strokes can come from it. So you really want to know if someone has had these kinds of consequences in the past. And with someone who is an IV drug user, certainly the propensity to develop bloodborne pathogens is very important. There's a subpopulation here in Nova Scotia, in Cape Breton, where more than 50%, probably in the range of 60% of people who inject drugs have Hep C, and many of them untreated still. So it can be a very, very high risk of these types of infections. And as well, most of my patients who've had a long history of IV drug use have had some issues with skin problems, skin infections, and some of them as well with endocarditis. I've had a few that have had more than one valve replacement. And with certain substances like crack, inhalation injury is a problem. You'll notice that some have a chronic cough or some laryngitis, and that can be very much related to their inhalation of the substance. And you really want to know about their non-substance use related conditions. If they have severe lung disease or heart disease, that's a completely separate thing. It may affect their treatment. So getting into the developmental history, Ron as well alluded to the adverse childhood experiences questionnaire. I think this can be a powerful thing to use with people. I like to preface it with asking people about what their life was like when they were a kid. And the question I ask is, what was it like in your house when you're growing up? And of course, if they just, say, oh, it was fine, I had no problems, and that's not unusual. But if they happen to either hesitate or give me a notion that there might have been some issues in their childhood, I use this ACE questionnaire, and it does correlate quite well to the development of severe substance use disorders. I want to know about their level of education, their special skills, because part of the way I'm guiding them as I go forward is to try to look at recovery being meaningful by putting some of those social pieces in place, like better employment or higher education. Goals, setting goals some of these goals can be educational goals. And I want to know about family history as well. I think we lose sight of the fact that that substance use problems aren't just nurture, that much of them are nature as well. The easiest way to illustrate that is statistically, we know that addictive disorders are more heritable than breast cancer and diabetes. Yet we don't think twice about asking somebody about their family history of breast cancer or their family history of diabetes as part of the screening. You want to do a physical examination. I think the most important part of the physical exam in this context is to do a mental health physical exam. A lot of this, of course, is just parts of observation and reflection on the conversation that you've had. You want to check a manual blood pressure, especially as it pertains to alcohol use. It's possible and actually common that when some of my patients who have an alcohol use disorder have been labeled as having hypertension, but when they manage to find recovery and abstain from alcohol, their blood pressure problem disappears. So I pay attention to blood pressure in the context of alcohol for sure. Always look in the nose. You'll sometimes be very surprised by what you see. What I'm looking for, of course, is evidence of perforations. What I often find are fragments of pills, the little plastic bits of the pill coating. Well, not plastic, but yeah, fragments of the particulate matter of the pills. And sometimes that can give you a clue as to what's been happening and for how long. You're also looking for stigmata of chronic liver disease. Signs of endocarditis. I'm not sure if anyone has ever picked up on Osler nodes or splinter hemorrhages. I haven't done well with that in my career. I think they're too subtle, but I would be listening for heart murmur and trying to detect a pulse on the physical exam. I look very closely for scars, not just on the arms, on the neck, on the feet. I have had one unfortunate patient whose preferred method of injection was injecting his genitals. So assessing impairment doesn't have to be complicated. If you look at just 3 parts to it, assessing their speech, whether or not they have slurring or mistakes or pauses, assessing their gait, if there's some gait ataxia or imbalance, assessing their level of consciousness. There are standardized tools that we have for determining substance withdrawal, and some of them are incredibly subjective, but very valuable if you really don't know if that's what you're dealing with or what you're seeing. A scoring sheet can be helpful. Keep in mind that these scoring sheets are specific to the substance. A CWA AR is specific to alcohol. A COW scale is specific to opioids. And if you don't know, or if there's a complex mix of substances, the recommendation I have is to just not try to figure it out in the moment by yourself, but to reach out to someone with more experience. If you have an addiction expert nearby, call them up and say, I have this strange mix of things. What have you seen? What do you think this might be? And bounce it off people. So when we look at patient factors, you want to try to determine with respect to the timing of last use, whether or not that fits with what you're seeing in front of you. Is this the toxicity that's resulting from the last use of opioids 12 hours ago? Could this be what I'm seeing because a stimulant was used before the person came in the department? We talked before too about that first use, regular use, loss of control, points in time to try to figure out where is a person on this journey to a substance use disorder. I also want to know whether or not a person has insight about any of this, what their reflections are on what's happening. And most people will tell you outright where they are and how serious the problem is as they reflect on it. And this is the ideal time to determine readiness for change or their stage of change. The fact that you're in front of you, I think, is one indicator that there might be more than just a pre-contemplative stage. And to start planting the seed about what the goals might look like. Certainly if a person is impaired or in the throes of withdrawal, a goal setting exercise isn't going to be done very early on in the assessment. This is something to come after there's a period of stability, at least physiological stability. I like to use a strengths-based approach. Tell me about your successes. What has helped you in the past? I also like to tease out what people's strengths might be or what they have a passion for. Even if they don't recognize in themselves that they have any specific skills, they know what they like. They know what their preferences are. So I ask them, what are your passions? You know, what do you really want to do? And if you could wave a magic wand and make everything different, you know, what would your life look like? Sometimes doing that very early on can be very impactful. What are their supports? Too often, my patients, when I see them for the first time, have lost a lot of their network, what they used to rely on for help emotionally or even physically. Isolation, I think, is one of the things that really feeds these disorders as well. But I want to know, what is your relationship right now like with your partner, with your friends, just to see how you might guide it changing over time in recovery as part of the goal setting. And one trick that has been gold throughout my entire career is, if you have any hint that people have a pet, find out what that pet's name is and let them talk about what their pet means to them and what kind of support their pet gives them. People get as much emotional support from pets as they do from humans. So looking at the DSM criteria, they define a substance use disorder as an array of mental, physical, and behavioral symptoms that may cause problems related to loss of control, strain to one's interpersonal life, hazardous use, tolerance, and withdrawal. I think that's pretty straightforward. I think we know what a substance use disorder is. Going through the questions, I like to put DSM questions in my own words to give it a comfort level with making it so that it can come out in conversation and not feel awkward. Otherwise, it's just a checklist and it seems clinical, like I should be wearing a white coat or something. Do you use more of this substance than you intend to use, or have you been using it for longer than you wanted to when you first started? That's the best way I've been able to come up with that criterion. Have you tried to cut down or stop without being able to, or without succeeding? Is using this substance taking up a lot of your time? Not just using it, finding it, using it, or recovering from using it. Is it eating up parts of your life that you don't want it to eat up? Do you have cravings? Do you have an obsession with this substance? You want to know somewhat about some of the consequences as well. And this next DSM question speaks to that. In what ways is this interfering with your responsibilities, if it is? And it's strange how often I come across this DSM criterion that I pose to somebody and they say, yeah, you know what? Nobody knows about this. And I get along just fine. I don't miss work and it hasn't affected my family at all. It's strange somehow how this doesn't light up in every patient. And with respect to it causing problems in relationships, you really want to define which relationships, get into some of the details, because those can pose some of the barriers to meaningful recovery. We have about 15 more minutes. I think we're doing well with time. You'll want to know about how much the substance has occupied space in a person's life that used to be occupied by other things. And this is the question that speaks to that. Has this substance use replaced important things in your life? I like to ask people, well, what is it that you used to love to do that you don't do anymore because of this? And that will help tease out some of their passions as well. You want to know about safety, and that's why one of these questions was built in. And the example I'll give, if people can't figure out, well, what does that mean? I'll say, are there instances where you've been so impaired that something could have happened without you remembering, like a sexual assault or driving that you really weren't aware that was happening? Driving is a key one as well, and you'd be afraid to go on the highway, I think, if you truly uncovered how many people drive impaired. The last couple of questions in the DSM speak to some of the compulsion, the inability to stop. Even though that you're aware this is a problem, do you find that you still can't stop using it? You know it's caused you physical problems, or some of these emotional problems that you've told me about are there, and then you keep using despite those. The last two are what people traditionally thought addiction was: tolerance and withdrawal. Is it taking more and more to have the same effect it used to have? And do you get sick or stop when you suddenly reduce your use or stop using? And I used to think before that, well, everybody who was taking an opioid prescription experiences these, but that's not entirely true. Certainly they may see escalations in their opioid dose as they become tolerant to it. But the way you experience withdrawal is you shouldn't if you don't suddenly stop your medication if you're taking it appropriately. So if a person tells you, this is what my withdrawal feels like, that means that there was a time that they encountered it, that something happened. It may have been of no fault of their own, but it's a clue. It's not black and white, and that's why it's only one of the criteria. So the 5 things that you can take home from this portion of today is that how you ask about substance use is probably as important or more important than what you ask. And that some of the emotions around substance use disorders involve shame. And if a person feels ashamed, they're less likely to disclose. It's important to make space and to use words that are safe, and to not to judge. Another is that you can't memorize everything, and that personally, I feel mnemonics are worthless. You have some tools close at hand, like the audit or the CWA or the COWS, just so that you can reach for them when you need to use them, embed them in your EMR. Not all substances are the same. Different substances respond to different treatments. We don't treat all cancers the same. This is really no different. An alcohol use disorder is not the same as amphetamine use disorder, a stimulant use disorder. They're very different things. And withdrawal syndromes are not the same as well, and we treat them all differently. I want people to know that it's important that we look at these as a chronic disease problem, and that your approach should be a chronic disease model, that the long-term treatments are what are impactful, the same way as the ways we manage heart disease and diabetes and asthma. And lastly, to be present, to use silence as a therapeutic tool, even when you're rushed on a treadmill all day long, like an average family doctor is. Pretend like you have all the time in the world, because it will make a meaningful difference for your patients. And that's it.
Thank you so much, Dr. Martell. You were ahead of schedule. you get a prize for that, because that's rare on a day like today.
I think the way it happens, Ron, is partly because you're speaking to a non-audience, right? Yeah,
that's true.
Nobody's interrupting.
You don't get distracted by anyone in the audience. So we will be having questions for myself and Dr. Martell at the end of block 2, along with Dr. Etches and Dr. Willows at the end of their session. So there's 30 minutes set aside for questions. At this point, I think we will take our lunch break, and we will reconvene at 12:30 Eastern time. Unless you're in the Eastern time zone, you're perhaps like me and constantly trying to calculate what time that's at. And we thank you so much for your attention this morning, and we look forward to seeing you all this afternoon.